presenting. I'll be presenting on behalf of Medicine 3. The title for the presentation is A Tale of One City. So this is Mr. A. He's a 29-year-old gentleman who works as an aluminum foil salesman. His work predominantly is office-based work. He's from a place called Girid in Jharkhand. He came with complaints of fever and abdominal pain for 6 months, cough and breathlessness for 2 weeks. So the fever was high-grade intermittent and it was present almost every day, associated with chills and rigors. It was associated with an upper abdominal dull aching pain. It was not related to food intake. There was no associated vomiting or loose stools. He also had cough which was associated with purulent expectoration. There was no hemoptysis and there was no diurnal or positional variation. And he also had breathlessness, which gradually progressed from MMRC 2 to 4 over 2 weeks. There was no history of orthopnea at PND, and there was no diurnal or positional variation. He did not have any history of travel during the last 6 months or any 1 or 2 months prior to presentation. There was no history of any exposure to, he never went for swimming or he never walked barefoot on any soil. And there was no history of any excessive rain in the town that he lived. And also there was no history of contact with TB. He is 29 years old and he was diagnosed with diabetes 1 year ago. The index HbA1c is not known, but his sugar levels was around 280 to 300 initially. He was started on oral medications and his sugars have not been well controlled. He is also a chronic ethanol consumer and he binges every 5 to 6 months. And he is also a current smoker. So prior to coming here, he went to other hospitals, which I'll talk about later. When he presented to us in December, the patient was tachypneic, he was tachycardic, and he was febrile. And on respiratory examination, there was use of accessory muscles, and there was also impaired dullness with consolidation, bronchial breath sounds. And on abdominal examination, there was tenderness in the right upper quadrant, and liver was liver was palpable. So now coming to the differentials, this patient has presented with a long history of fever, with cough and breathlessness and upper abdominal pain, with a background history of young onset diabetes, which is not well controlled, and history of chronic ethanol and smoking. So our differentials were the following. We thought it could be a disseminated TB. We thought it could be infective endocarditis with hepatic or splenic infarcts causing the abdominal pain. Because of long-standing diabetes and uncontrolled sugars, we thought it could be some chronic pyelonephritis, liver abscess because of the more prolonged duration of fever, and because of ethanol consumption, we thought he could have occult abscesses or any hematological malignancies or solid organ tumors causing fever like HCC, RCC, or disseminated melioidosis. So coming to the treatment history, which I didn't cover, he was taken to a local hospital after 2 months of the onset of fever. So they had done imaging. He was found to have a swelling on the right side of the neck. And also imaging had shown multiple abscesses and splenic vein thrombosis and thrombosis of the right EGAV subclavian vein. So for the swelling in the right neck, aspiration was done and culture was sent. So the culture had grown Pseudomonas aeruginosa and he was treated with antibiotics for the same. Now, when he presented to us, he was anemic. There was leukocytosis, which was neutrophil predominant, and his sugars were uncontrolled. The rest of the basic investigations were not significant. When he presented with respiratory distress. So he was hypoxic and he also presented with a respiratory alkalosis. So because he had features of suggestive of a consolidation, we did a chest X-ray. We can make out there is a cavitatory lesion on the left upper lobe, and cross-sectional imaging also shows consolidation with a cavity. The abdominal imaging showed multiple liver abscesses in the liver and as well as spleen. So
what are your differentials now?
So I still think because of uncontrolled diabetes, it could still be a disseminated TB. It could be melioidosis and infective endocarditis, but it won't explain the.
What are the other differences?
Again, liver abscesses.
Like
chronic, because of his presentation, we were thinking of amoebic, but there's multiple here. But if it's a pyogenic, they'll present with a more acute presentation.
Any other organism you can think of? More common in alcohol? Kleb. Hypervirulent Kleb.
So we had taken a sputum culture as well as we put a hepatic drain and we sent both for cultures, and both had grown Burkholderia pseudomallei. Now coming to another patient who is from the same place who presented to us at the same time. They're not related, but they're acquaintances, and they have some common friends. So he is also a 29-year-old man who's a hotel manager. He's also from the same place. He had presented with fever since October, and he also presented with breathlessness and expectoration, and he was treated outside for a community-acquired pneumonia. And within 1 week of being treated as a community-acquired pneumonia, he developed left-sided upper and lower limb weakness and slurring of speech. And within 24 hours of that onset, he developed right-sided weakness also. And he had also complained of swelling and pain over the right knee. So we have done our evaluation, and we have also found that he has melioidosis, and we are treating for it. So melioidosis has been presented multiple times. So I'd like to cover a different aspect, that is a preventive aspect of melioidosis. So before going to that, just a brief introduction about what it is. It is caused by Burkholderia pseudomallei. It is a gram-negative, oxidase positive, non-lactose fermenting bacilli. So it resembles a pseudomonas. So if you notice that our patient, the initial culture outside had grown pseudomonas, and he was treated for that. So if the labs are inexperienced, most of them can report Burkholderia pseudomallei as pseudomonas, and they can be treated wrongly. So it is a facultative intracellular bacterium, and they're intrinsically resistant to penicillin, ampicillin, first and second generation cephalosporins, and even polymyxin. So we cannot use colistin to treat all of that. The route of entry can either be inoculation, inhalation, or ingestion. The clinical presentation is varied, and it can mimic anything. So it's also called the great mimicker or the masquerader. And disseminated melioidosis is very similar to how disseminated TB presents. So it can affect the CNS system, causing brain abscesses. It can affect the cardiovascular system, urinary tract system. It can affect the respiratory system, causing pneumonias, or even cause liver abscess, splenic abscesses, or even soft skin and soft tissue infections. So coming to the treatment, so there are two phases of treatment. One is the initial inductive treatment, and the other one is the eradication phase. So in the initial part, we usually give it for 2 weeks unless there is CNS involvement, or if the patient is in ICU, where we give it for a prolonged duration, either 4 to 8 weeks. And the goal of the induction phase is to reduce the mortality because of the melioidosis. In the second phase, which is the eradication phase, we give oral antibiotics, and the goal of treatment is to prevent the relapse. So in the initial phase, the antibiotic of choice is ceftazidime, unless the patient has CNS involvement, or if the patient goes to ICU, where meropenem is preferred. And if a patient presents with a non-pulmonary focus of infection, like whether CNS or even prostate or other abscesses, then Septran should also be considered, should also be added in the intensive phase. In the eradication phase, we give oral Septran. It's usually for 3 months, again, unless CNS is involved or bone is involved, where the duration is for 6 months. And if there is mycotic aneurysms or vascular graft, then the treatment duration is lifelong. If a patient cannot tolerate Septran, then we can give doxycycline. But the patient also has to be treated. So if there is an abscess, the abscess has to be drained, and we can also give supportive care. Now coming to prevention, why is it important to prevent melioidosis? So if you see this graph, it was published in Lancet. We can see that more than 90% of the Burkholderia cases have been reported in the last 10 years. This is mainly because the labs are now better equipped to make a diagnosis, and also the clinicians are more aware of this condition. So this is a map of India. This shows where the regions where the cases are reported from different parts of India. So here we can see that in Karnataka and Tamil Nadu have a lot more cases of melioidosis. This is probably because we have better centers to make a diagnosis. And these are the centers which are equipped to diagnose melioidosis, and you can see that CMC Vellore is one of them. So this is a study that was published in CMC. It's a retrospective study. We had taken cases from 2008 to 2014 and seen 115 cases. So here we can see that majority of the cases, around 26.3 cases, are from West Bengal. The reason why it is not shown in the previous graph is because probably there is no better lab to make a diagnosis. So according to the same study that we have seen, we have found out that the risk factors are mainly uncontrolled diabetes and harmful ethanol use. So for our first patient, the patient had both. He was a young onset diabetes with poorly controlled sugars, and he had chronic ethanol consumption. The second patient, who was his acquaintance, even though he was not a diabetic, he was also a chronic ethanol consumer. So usually melioidosis is seen in tropical countries, and it's not seen in countries like USA. But there was a study which was published in NEJM where they had seen that in 2021, there were 4 cases that were published. There were 4 outbreaks of melioidosis in US. 2 of them were children aged 4 and 5, and the others were elderly 45 and 56 with comorbidities. So when they looked at to see what had caused the Burkholderia, they found out that all of them were caused by the same strain of Burkholderia pseudomallei, and the culprit was an aromatherapy which was imported from India, which is endemic to Burkholderia. So coming to the prevention part of it, we know that Burkholderia gets transmitted by either inoculation, inhalation, or ingestion. So it is important for one thing that clinicians should be aware, and we need to have good labs to make a diagnosis of the Burkholderia. And finally, the management should be good, where the patient does not receive only the intensive therapy, but also the eradication therapy to prevent relapses. So how do we prevent? Since the transmissions by inhalation, ingestion, or inoculation, we have to make sure that we should avoid contact with contaminated soil or water. So a farmer going to the field should wear knee-length boots, or if they have an ulcer, they have to have waterproof dressings, and they should have good sanitation and good water facilities, and all the comorbidities like diabetes should be well controlled. And also it is important that the public is also aware. So there are 2 newspaper articles, one that was published in India and one in Sri Lanka, where they had actually said that Burkholderia is caused because of diabetes. And in Sri Lanka, they published that saying post-rainfall, Burkholderia can increase. So it is important to create awareness in the public area also. And is there any role for post-exposure prophylaxis? So it is recommended in patients who have laboratory exposure, or if they're exposed to bioterrorism or any exposure to aromatherapy, as we have seen earlier. So the dose, the treatment is Septran or Augmentin, and is given for a duration of 21 days. So coming back to Mr. A, so we had initially, because he had presented with multiple abscesses, we had initially treated him with meropenem and teicoplanin. He was in ICU. But once he got a microbiological evidence of Burkholderia, he was changed over to meropenem, Septran, and doxy. So he's planned for 6 weeks of induction therapy, followed by 6 months of eradication therapy. His acquaintance, who was also admitted with us, he had disseminated Burkholderia, including the CNS. So he was also started on initiation phase with meropenem, Septran, and doxy, and he's planned for 8 weeks of eradication therapy. Physiotherapy is being continued, and he has clinically improved. So take-home points, I was just covering the preventive aspects. So it is important for clinicians as well as the public to be aware of Burkholderia, and we need to have a high degree of suspicion for the same. Otherwise, it can be reported outside as a different organism. And prevention of the disease plays a major role in the control of the disease and about the treatment.
Thank you, Tephilah, for the case presentation on melioidosis. As you rightly said, it's a disease which can mimic TB, and diagnosis is a little difficult unless you have the expertise in the lab. And most of the labs don't pick up melioidosis. And as you rightly pointed out, there are places in Karnataka like Manipal and CMC Vellore. And we do get a lot of cases from Bhubaneswar as well. So wherever there is increase in rainfall, during that time you do get melioidosis, as you said, risk factor being diabetes. And treatment wise, you need to give meropenem and ceftazidime, and both are susceptible as of now. We don't find any resistance to these 2 antibiotics. So patients who are sick, we do give meropenem. We can actually give them. You know anything about therapeutic drug monitoring and treatment for melioidosis?
There's a study published from CMC. I think the level should be more than 5 times the MIC of the meropenem, and it's better to give as an infusion.
Yeah, so ideally we should give it as an infusion because melioidosis is an organism which can cause these micro abscesses. So you need to make sure you have a steady state. To maintain that, you need to give it as a meropenem. You actually give a high dose of meropenem over a period of time, especially in the ICUs when they're critically ill. We give 2 grams IVQ 8 tali. And we also look at the MIC of meropenem. And our target should be at least 4 to 5 times the MIC, that is the meropenem trough levels. So you need to monitor that. You need to monitor the patient's creatinine and maintain the steady state. And then once the patient is stable, then you can probably change over to captacidin. And as you rightly said, patients with bone involvement, it's good to add Septran in the initial phase so that they have a better clearance. So these 2 patients are from where?
Girid, Jharkhand.
Jharkhand. One patient had a neuromyelioid.
Both are disseminated neuromelioid, bone and pulmonary.
Any history of dental procedure for them?
So,
No.
no.
Dental check, nothing.
Okay.
Because we discovered that they are both.
From the.
If both are together, we discussed the case. Because one was an IC, one was in. We actually came back to what together and we found that both were from the same place. Not close contacts. It is 5 kilometers apart, but they have same range.
And water? Water supply? Water supply, where were they getting from? Any? I mean, it's good to ask that, and if possible, to get that water from there.
Cause to say why should 2 people from the same area who are kind of, even if they are acquaintances or cousins, why should they both get, and both are disseminated. One is a polycontrol addict, the other one is an alcohol consumer who is COPD. The risk factors are there. Obviously, there's more.
Yeah, because interestingly, we also, I mean, ma'am knows that we had a case series of patients who had actually had dental extraction. And we did find that patients who went to a particular dentist, about 20 of them had neuromyelioidosis, and the mortality was close to 50%. And when we looked at when we sequenced when we cultured the water from the dental, it grew myeloid, and when we sequenced, it was the same type. That's how we closed the outbreak investigation. I mean, you need to get a good history in terms of any visit to the dentist and the water supply, especially in Jharkhand. People who have been, even one of the risk factors, people who are working in the bore well, people who dig the bore well, and if they're diabetic, they also becomes a risk factor for getting myeloid. Okay, thank you. So we'll go to the last case.